second in our series of heart health talks that we wanted to try to get in before we had the walk on June 11th. So if you haven't had a chance to register for the walk, I'm going to remind you about that. And we've had great turnout, and I think it's a testament to Breckenridge Grand Vacations and Rob and Mike. We have exceeded our goal of $100,000, but we want to see how high we can go. So if people say, oh, I don't need to sign up or support it, yeah, we're like at $140,000.
Really? Well,
awesome. So let's see. I mean, you know, we're kind of a competitive community and a competitive group, so let's just see how high we can go. It's my pleasure to introduce to you Dr. Warren Johnson, and I've known Warren
a long time. About 8 years.
8 or 9 years. I was working at the hospital for the Hospital Foundation when we started the cardiology department, and Warren came on board. And his credentials are impeccable, and we're lucky to have him in our community. A community of our size, to first of all, 8 or 9 years ago, have a cardiologist, but now to have 2 cardiologists. I'm not sure if that's good news or bad news, though, Warren.
Well, it's full time now.
So obviously, living at altitude has its challenges. We all know that. But I'll tell you a little bit about Warren. He was trained at the University of Kansas Medical School, received his internal medicine and cardiology education at the Mayo Clinic. He was a cardiology consultant at Mayo until he moved to the Mid-America Heart Institute in Kansas City. And Dr. Johnson was an interventional cardiologist in Kansas City until he moved to Summit County full-time. This is 7 years ago, but I think it was longer ago than that. And his office is affiliated with St. Anthony Summit Medical Center in the medical office building in Frisco. But Warren's not new to Summit County. He and his wife Becky have owned a home in Keystone
since '91.
So he knows about high altitude, and obviously he's living here now because he loves this community. So with that,
good. Well, thank you.
Well,
good. And then, it's great to have you, as many of you are here. This is terrific. That's my wife. She does things that I like to do too. So with high altitude, this is up in Alaska, but since Deb introduced my wife a bit, I thought I'd tell you about that. So what I'm going to talk to you today is about the reasons that we have shortness of breath, how we all have periodically, when we go back and forth from a lower altitude, we all have to acclimate. But what's really interesting, because most people know about that, and we know how to help people with those acute short periods of time when people come up to the altitude. What's most interesting to me is the people that live up here full time, because when I first came, and this is the talk today, we now know how things physiologically are starting to cause some of us to have more and more difficulty. Most of it is with the genes that we have, and we're all a little different, but some people can't tolerate it at all, and others can do pretty well. And so the idea about getting the research program up and going is because of that. We need to know the prevalence in our community about how many people have it. And we're going to be looking at that with different ages, and we'll be looking at a group of individuals with a study that we're thinking about doing here just shortly at least I'd like to get it going before the fall, but we have to go through the IRB to get everything okay and some of that. Well, at any rate, let me just make some comments about the altitude. Many of you have been up at higher altitudes, climbing up on most of the peaks around here. But where we sleep is where things really happen. And our county has a little less than 8,000 when you go further north, but it gets Kremling, it's about 7,000. But this is where most of us live, right up here, in the 8,000 to 12,000 level. There's very few people that live above, well, there's nobody that lives above 20,000 feet, and I'll show you that in just a minute. But this is where many people play and go climbing and those types of things. But the high altitude where we sleep is the most important. I only have about 2 or 3 slides that are going to be a little interesting, and so just pay attention a little bit here. This one is the altitude, so from 0 up to 30,000 feet, and the barometric pressure is from 760 up to 226 barometric pressure. That's in millimeters of mercury. This is not linear. This is logarithmic, and so in this area right here, and this is the reason that as we go up higher and higher, every 1,000 feet is harder and harder for us to deal with the atmosphere. The pulmonary, or the partial pressure of arterial oxygen saturation is also what's happening in our bodies. And so at sea level, we have very normal pulmonary arterial oxygen saturations. And you can see that as this goes higher, it's not linear. This red line is the PiO2, that's the inspired oxygen that you're getting. This is a little wrong because Denver should be right there, Leadville should be right there, and the Mount Everest should be up a little higher, but nevertheless you get the idea. And that's the reason that the higher we go, the worse it gets. So there are about 140 million people on the earth that can tolerate the altitudes where they live, and they do very well. And these are people that are over 8,200 feet. Most of them have been in areas for their families have been there for years. There are genes that can be changing. Ethiopia happens to be the oldest and the most completely adapted. And you know that when they win all the races, right? So they live at up to 3,500 meters, which is about 14,000 feet. And that group of the Amara, they've been there for 5,000 years. The others have been up there for 70,000 years. The Himalayas is the next oldest, and that's 5,000 years. And you know the Tibetans and the Sherpas, they can do a lot of things. They have no problems. Just 2 weeks ago, there were 9 Sherpas on Everest, the first people this year up there on the top of Everest, and they all did it just fine. In 1998, when my wife and I were at base camp of Everest, we were having the dinner with the American team, climbing team, and they got a call from some of the Sherpas up on Camp 3 saying, "We need cigarettes." And so, you know, they are very well acclimated. Those Sherpas, they have changed. They evolved with larger lungs, and they also have an automatic, faster respiratory rate. And for us, we have enough respirations during the day for most of us, but we don't have that at night, and I'll talk to you about that in just a minute. The Andes is next, and they've been there for about 2,000 years and so they also have some issues, but we're the worst. Rocky Mountains, we're the youngest, we're the least adapted, and the three highest counties in Colorado, Summit, Lake, and Park, have over 50,000 people that live up here full time. And that's the reason that we're very interested in trying to help those individuals. When I first came up here, there were many people that were having more and more shortness of breath. And when we started to, the recommendations at that time was, well, you need to go down to a lower level. You need to get out of here. It turns out that was in 2009. There was a recession. Nobody had a job anywhere else. Those people could not go down and get a job. They had their homes. They couldn't sell them. And so they just said, you know, help me. So that's when I really got interested in the low oxygen, which is called hypoxia up here. So this is a group of individuals that's been had been here as the only people for a long time. And then if we look at the population of Summit County, in World War I, we only had 1,000 people that lived up here. So there's that the gene pool that was in World War I. Even in 1970, before the ski industry came alive, it was just about 2,700 people. And then we had the explosion with all the population increasing at 230% each decade there, and it's still moving on. So we need to help these people to identify what we need to do. This is an interesting study in 1993 where the pulmonary artery pressure, the mean pressure, was evaluated and with the oxygenation or the oxygen saturation, and you can see that. And so in the normal is 15 millimeters of mercury. As the oxygen saturation goes down, the pulmonary pressure starts to go up. And I'll show you why that happens later. But that the North Americans, when we're down at about 50, we are way up here. And these people are very ill. The South Americans, and then look at the Tibetans. They can go way down to just in the 30s. So that's what happened. This is one more slide I want to show you because this is the mechanism, the physiology of what happens when we get acute hypoxia, and most of that is associated with nighttime sleep. So if the oxygen saturation goes down, the pulmonary artery the pulmonary artery vessels have vasoconstriction. That's the only thing it does. We're born that way, and so that mechanism causes pulmonary hypertension, not regular blood pressure. The systemic the systemic system, just our blood pressures, usually causes vasodilatation unless we have the sympathetic system that will increase the adrenaline, increases heart rate, blood pressure, all of that. And that's the reason why each of those things happen. This is the most important part of the talk, is the pulmonary vascular constriction. This is the gene that was identified actually several years ago. It's the hypoxic gene, and it's a hypoxia inducing factor. It's called alpha-1. And this is a picture, of course, of how these things work. It's not the gene, you can't see it, but this is how each of those proteins work. That turns on 1,500 other genes. So you can see we're not uniform, and we don't know what most of those genes yet are doing. But some of those, I'm sure, help, and others aren't very helpful. So the other thing that I wanted to talk about, but we're going to just speak primarily to pulmonary hypertension, but sleep apnea is very common up here. It's very common at lower altitude. The difference is up here, our sleep apnea is central sleep apnea, which is related to your respiratory rate. It's your brain that is triggering that. Whereas obstructive sleep apnea is the airway obstruction with snoring, and that down at lower altitudes, it's mostly obstructive. Up here, we have 75% central sleep apnea and 25% a combination of those. But we have those individuals. I only have one or two people that are not on oxygen that have sleep apnea. And that's, so if you think about that atmosphere that we were talking about, that as you breathe up here, you need to breathe about 15% more because the air is thinner. So the oxygen, you have to breathe more, and it's about 15% more per minute, day and night. During the day, while I'm talking, I'm breathing a little bit more, and that's automatic. At night, when we go to sleep, our genes control our rate, and the rate is at sea level. So we become hypoxic, many of us. So some of those genes that are helpful help some of the people, and there are others that at night it gets worse. So we can also have blood pressure elevation, heart failure, coronary spasm. Perhaps we see some of the people that have been competitive up here, they skidding up on some of those races. They've had a heart attack during the race, and we take them and do a catheterization, and those don't have plaque, cholesterol. Most of them it's probably spasm or just a clot, and arrhythmias are another cause. Well, we're going to talk primarily now about the pulmonary circulation. So the blood that comes back through the venous system goes to the right atrium, and then goes through the tricuspid valve into the right ventricle, and the blood then goes into the left and right pulmonary arteries, and where all the action then is just before the capillaries. And here's what happens with with hypoxia and some chronic illnesses. So let me just get this. So normally, the pulmonary arteries are very thin. They are very active. They can dilate and they can constrict. And you can see here, this is the very thin vessel just before the capillaries, and that's where the constriction happens. The cardiac output is normal for a while. When the pulmonary artery pressure starts going up, we also get what's called PVR, that's a pulmonary vascular resistance, and that is what we measure to see if these pressures are normal or not. And the New York Heart Association stage 1 is identified by no symptoms, but the disease has already started. Okay. If we look at, as time goes on, and this is a reversible problem, look at the difference as we get into symptomatic. This is stage 2 is just very light symptoms with exercise, and 3 is quite limited, and the thickness is there, and it's starting to become more and more pressure in the lungs, and the resistance is also going up. And this is a protein that we can measure in the blood. It's a BNP, and when there is stress on the heart, this protein starts to be going into the blood from the heart, and so we use that as a marker as well. If we look at the cardiac output, we see that for quite a while we're doing pretty well, but when this starts to happen, that's when I typically see people call and say, look, I need some help. Why am I short of breath? And it's because, and some of the individuals that work up in the ski industry and so on, they will see that last year they were ahead of everybody, and this year they can't keep up. And so that's what the symptoms we see. Let's see what, sorry. There. So this is the end stage. What we want to do is identify these people here as soon as possible. And that's the reason we want to do this study, to see the prevalence of the population that we have. And the cardiac output, you can see, goes down. Even the pulmonary pressure goes down because the cardiac output is going down, but the resistance continues to go, and many of these people end up with oxygen full-time and a very short life. But you can see there's blood clots, there's tissue that grows in these plexiform lesions and so on. Well, that's the mechanism, and we can talk about that if you want afterwards. But that's how we measure it in our cath lab up here, and how we will take those individuals and have a catheterization to measure the pulmonary pressures and the cardiac output and the resistances, and then we give them oxygen 100% for 10 minutes with nitric oxide, and that, if it relaxes and the pulmonary pressure gets better, then we can use some medications to help with this problem. Well, if we look at pulmonary hypertension in the USA, we see that pulmonary artery hypertension is only 15 per million. there is a thing called an idiopathic hypertension, which we don't know what causes it, but that's just about 6 per million. And with blood clots, once they've had a blood clot, only about 3 to 5% of the individuals have a pulmonary hypertension. And so there are other diseases here, but the high altitude is the question for us. This is my first year that I was up here, and I didn't have an electronic medical record, but I did keep a document on all of the patients. And the first year, there was 46 patients. So if you can imagine, it's nothing like down at lower levels. It's a much different, and that's what we're going to be looking for. The way we measure this without catheterization is with an echocardiogram. This is, and we can look at this right heart that we were just talking about before. We can, if there's a leak in this valve, just mildly, we can measure that gradient and know the pressure here pretty closely. So that's the way we identify it generally. And then we have several different tests that we do, and ultimately, most of the time, if we can identify it early and we use oxygen supplementation at night, then that tends to make that pressure go back down to normal. This is the last slide I have, that just to show you the difference of workload exercises up here. So at sea level, the normal heart, you can generate about 7 or 8% less up at this altitude. If you have mild heart failure, it's about 15% less. And if somebody has heart failure that's severe here at sea level, they most likely won't make it up here. So these are some of the things that we look at. Good. We do have the reason we want to get into the research for this is because we have many individuals that have altitude intolerance. We have numerous unknown questions there about how to help people, and the highest population in North America is these 3 counties. So we're a very unique population up here. And when I sent patients down to Denver to have casts done, then they would say, "You're fine, go back up, you'll be fine." But that wasn't the case. Good. So any questions about this?